What I'm about to show you may completely change how you look at the little blood pressure pill sitting on your kitchen counter right now. Because if you're over 60 and you take medication for hypertension every day, there's something almost nobody explains clearly enough. Some of the very pills that help protect your heart and lower your stroke risk can, under the wrong conditions, quietly push your kidneys into trouble before you feel a single warning sign. And that's what makes this so dangerous. Kidney damage rarely announces itself early. It doesn't usually begin with sharp pain or some dramatic collapse. It begins in silence, in tiny drops in filtration, in rising creatinine, in potassium shifts, in dehydration you didn't realize mattered. And by the time symptoms finally appear, the damage may already be well underway. I'm Dr. David M. Reed, and today I need you to listen very carefully because this is not one of those videos where I tell you all medications are bad. They're not. Many of these drugs save lives every single day. They prevent strokes, they reduce heart failure, they protect blood vessels. Some of them even protect the kidneys in the right patient. But after 60, the margin for error gets smaller, and that's the part so many seniors never hear. Your kidneys become less forgiving. Your body handles dehydration differently. Drug combinations become more dangerous. One stomach virus, one heat wave, one over-the-counter pain reliever, one dosage increase, and a medication that was safe last month can suddenly become the reason your kidney numbers crash this month. Before we begin, please subscribe now so you never miss doctor-guided videos that help protect heart, kidneys, and independence. And here's what worries me most. Somewhere right now, a senior is looking at a perfectly normal blood pressure reading and assuming everything is fine, while their kidney function is quietly getting worse in the background, not because the medicine is evil, not because the doctor made some outrageous mistake, but because the medication was never meant to be taken in isolation from hydration, lab monitoring, age, kidney reserve, and the rest of the pill box. That's the missing conversation. Blood pressure medications don't operate in a vacuum. They operate inside an aging body, and an aging body has less room for miscalculation. By the end of this video, you'll know the 5 blood pressure medications I watch most carefully in people over 60, the warning signs that should never be ignored, and the single medication category I'm saving for last because it surprises almost everyone. Before I reveal number 5, you need to understand one principle that changes everything. Kidney damage from blood pressure medication usually does not happen because the medicine suddenly becomes poisonous. It happens because the kidneys lose the pressure, fluid balance, or electrolyte stability they need to keep filtering blood safely. Think of your kidneys like a delicate filtration plant. They need just enough blood flow, just enough pressure, just enough fluid, and just enough chemical balance to keep working. Too little fluid and filtration drops. Too much potassium, and the whole electrical system of the body becomes unstable. Too much medication during dehydration, and those filters begin to struggle. That's why a medication can be helpful in January, harmless in March, and dangerous in July after 2 days of vomiting, poor appetite, and not enough water. Same pill, different body conditions, very different outcome. And that is exactly where number 5 begins. Let me tell you about Gloria first, because her story reveals medication number 5, and it starts in such an ordinary way that most people would miss it completely. Gloria was 71, careful with her health, proud of how responsible she'd become after her blood pressure went up in her late 60s. She took her pills every morning, walked 3 times a week, kept her appointments, and rarely forgot a dose. Her doctor added hydrochlorothiazide, a common water pill, because her numbers were staying a little too high. At first, everything seemed fine. Her ankles looked less puffy. Her blood pressure improved. She felt encouraged. Then summer arrived. A few hotter days, a little less appetite, more sweating in the garden, and Gloria started feeling tired. Not sick exactly, just off. Her mouth felt dry. Her legs cramped at night. She became a little lightheaded when she stood up. She assumed it was age. It wasn't. Medication number 5 is hydrochlorothiazide. And this one matters because it's so common that many seniors stop thinking of it as a powerful medication at all. It's often described casually as a mild water pill, but mild does not mean harmless. Hydrochlorothiazide helps lower blood pressure by pushing the kidneys to remove more salt and water. That can work beautifully when your body has enough fluid reserve. But after 60, fluid reserve changes fast. Thirst signals can be weaker. Appetite can dip. Hot weather hits harder. A few loose stools can matter more. And when hydrochlorothiazide keeps pulling water and sodium out of the body while the body is already running low, your kidneys can become underperfused. In plain English, they don't get the blood flow they need. Add in low potassium or low sodium, and you start moving toward confusion, weakness, cramps, dizziness, and kidney stress that may first show up only on lab work. When Gloria finally had blood tests, her kidney numbers were worse, her potassium had dropped, and the problem wasn't that hydrochlorothiazide was a terrible drug. The problem was that nobody had connected her summer dehydration, poor intake, and ongoing water loss from the pill. That's the trap with number 5. It doesn't usually create one dramatic red flag. It creates a string of small ones: less urine, stronger smelling urine, more fatigue, more thirst, a little faster pulse, cramps in the calves, maybe even mild nausea. You brush them off one by one, and meanwhile the kidneys are taking the hit. If you're on hydrochlorothiazide, especially after 60, you cannot treat new weakness, new dizziness, or reduced urination like minor annoyances. Those can be kidney warnings, not just getting older. Now here's where the conversation gets more serious, because medication number 4 looks similar on the surface, but it can hit harder and linger longer than many seniors realize. And the really unsettling part is that some people are switched to it specifically because it's considered stronger or longer lasting. That can be helpful for blood pressure. It can also create a bigger problem for the kidneys if the body can't keep up. Let me tell you about Walter, because his story exposes why number 4 deserves far more respect than it gets. Walter was 74, a retired bus driver, and he had one of those personalities doctors love. He followed instructions. He showed up on time. He wrote everything down. When his doctor changed him from hydrochlorothiazide to chlorthalidone, he figured it was just a better version of the same medicine. Stronger control, same general idea. No big deal, all right? That assumption cost him. Medication number 4 is chlorthalidone. And this is where I need you to pay close attention, because older adults often assume all thiazide-type diuretics are interchangeable. They're not. Chlorthalidone tends to last longer and can produce a more sustained effect, which means it can also produce more sustained fluid and electrolyte losses in the wrong patient. In older adults, that matters. A large cohort study in older patients found chlorthalidone was associated with a higher risk of a meaningful decline in kidney filtration and a higher risk of low potassium compared with hydrochlorothiazide. Now, that does not mean it should never be used. It absolutely can be the right drug, but it does mean this is not a casual switch. If you're over 60, your kidneys deserve follow-up after dose changes, hydration changes, appetite changes, or new illnesses. Walter didn't get that message, and his body paid the price. But number 3 is where the danger starts becoming harder to ignore, because this medication doesn't just dry you out a little. It can empty fluid fast, and when that happens in an older body, the kidneys may suddenly find themselves trying to filter blood with far too little volume. Let me tell you about Lorraine. Lorraine was 78 and had swelling in her legs from heart failure as well as high blood pressure. Her doctor prescribed furosemide, and at first the relief felt incredible. The swelling dropped, her shoes fit again, she could breathe easier. She even lost 6 pounds in a few days and thought, well, this must be wonderful. But what Lorraine didn't understand was that losing water too fast can feel like success right up until it turns into kidney stress. She started becoming dizzy when she stood up. Her urine got darker. Her mouth felt sticky. She felt strangely sleepy in the afternoons, and she began peeing less, not more. Medication number 3 is furosemide, also known as Lasix. This is a loop diuretic, and it is a powerful one. It can be life-saving in the right setting. If fluid is backing up into the lungs, if swelling is severe, if the heart is struggling, this medication can provide real relief. But after 60, power cuts both ways. Furosemide works by telling the kidneys to dump salt and water aggressively. That's exactly why it helps fluid overload. It's also why it can overshoot. If you lose too much volume, the kidneys don't get enough blood flow and can slip into what we call pre-renal injury, which basically means the kidneys are starving for circulation. Add vomiting, diarrhea, poor appetite, summer heat, or another blood pressure medication on top, and the risk climbs fast. Serious side effects can include reduced urination, dehydration, dizziness, blood in the urine, even inflamed kidneys. And none of that begins with fireworks. Lorraine's doctor eventually realized that the issue wasn't that she needed no diuretic. It was that she needed closer monitoring, better guidance, and a plan for what to do when her daily weight dropped too quickly or her appetite disappeared. And this is where number 3 gets even more dangerous. Seniors often combine it with other kidney stressors without realizing it. A little ibuprofen for arthritis, a skipped meal, a stomach bug, less water because they don't want to keep running to the bathroom. Suddenly, furosemide is not just removing excess fluid, it's helping create a perfect storm for kidney injury. And if you notice new thirst, dark urine, weakness, confusion, lower urine output, or a blood pressure that seems unusually low while on furosemide, that is not the moment to wait and see for a week. It's the moment to call, review the dose, and protect the kidneys before the decline becomes deeper and harder to reverse. Now we move to number 2, and this is where people often get blindsided because the risk is not just dehydration, it's chemistry, specifically potassium. And potassium problems are dangerous because they can affect the kidneys, the muscles, and the heart all at once. Let me tell you about Raymond. Raymond was 69, stubborn, intelligent, and absolutely convinced that if a medication had been prescribed to him, it must be safe in every circumstance. He had resistant high blood pressure, so his doctor added spironolactone. His numbers improved. Everyone was happy. Then Raymond started feeling heavy. Not swollen exactly, heavy. His legs felt weak climbing stairs. He had strange episodes where his heartbeat felt slow and irregular. He thought maybe he was just out of shape. He ignored it. When he finally got blood work, his potassium was dangerously high and his kidney function had worsened. And this is what makes number 2 so deceptive. It often starts with vague symptoms, not dramatic ones. Medication number 2 is spironolactone. This drug can be extremely useful, especially when blood pressure stays high despite other medications. It can also help in heart failure, but it is a potassium-sparing diuretic, which means unlike the water pills that flush potassium out, spironolactone tends to make potassium stay in the body. In the right patient, that's manageable. In the wrong patient, especially after 60, it can be a serious problem. If kidney function is already reduced, if the person also has diabetes, if they're dehydrated, if they're taking an ACE inhibitor or ARB, if they use potassium supplements or salt substitutes, or if no one is checking labs after starting the drug, potassium can rise quietly and the kidneys can struggle at the same time. National Kidney Guidance specifically warns that spironolactone can raise potassium and needs regular follow-up. Because high potassium is not something you want to discover by accident. And it gets worse. Studies in real-world patients have shown that when spironolactone is added on top of loop diuretics, the risk of hyperkalemia and acute kidney injury goes up. That means number 2 is not just a standalone concern, it's a combination concern. A pill added to another pill added to an aging kidney. That's the pattern I want you to see. Raymond's trouble did not come from one reckless choice. It came from a sequence that no one fully respected. He had high blood pressure, he needed stronger control, the medication helped, he felt mostly fine, and because he felt mostly fine, everybody relaxed. Meanwhile, his kidneys and potassium were moving in the wrong direction. If you're on spironolactone, warning signs like muscle weakness, tingling, new fatigue, palpitations, reduced urine, worsening dizziness, or nausea deserve attention. And if you've never been told to ask about potassium, kidney tests, and salt substitutes, that conversation is overdue. Which brings us to number one, the medication category I saved for last, because it is the one most likely to shock you. Not because it is the most reckless prescription in medicine, not because it is bad medicine. In fact, the opposite is true. Number one is prescribed precisely because it often helps protect the kidneys, and that's why it becomes so dangerous in the wrong moment. People trust it more. Doctors use it more. Patients assume it can only be doing good. So when the kidneys begin to suffer, nobody thinks to look at the very pill that seemed protective in the first place. Let me say this carefully. This medication class has helped millions of people. It slows kidney disease progression in the right setting. It lowers blood pressure. It reduces harmful pressure inside the kidney filters. But in a dehydrated body, or when combined with other stressors, that same protective mechanism can suddenly become too much, and kidney function can fall fast. Medication number one is lisinopril, and the same caution often applies to its close relatives in the ACE inhibitor family and to ARBs like losartan. Let me tell you about Helen. Helen was 76 and had done everything right for years. Her blood pressure was controlled. Her diabetes was decent. She took lisinopril faithfully because her doctor told her it helped protect both her heart and her kidneys. And usually that was true. Then she caught what she thought was a simple stomach virus, 2 days of nausea, 1 day of diarrhea, very little food, barely any fluids. She kept taking her lisinopril because she was disciplined. She also took a few doses of ibuprofen for body aches because she felt miserable. And she stayed on her diuretic because nobody had ever given her a sick day plan. By the time she reached the clinic, her urine output had dropped, her blood pressure was low, and her kidney numbers had jumped into dangerous territory. That is number one in real life. Here's why number one is so tricky. Lisinopril and similar drugs reduce pressure inside the tiny filters of the kidneys by relaxing the blood vessel that carries blood away from those filters. That lower pressure is one reason these medications can protect kidneys over time. But if overall blood flow to the kidneys is already low because of dehydration, low blood pressure, or aggressive diuretic use, the kidneys may no longer have enough pressure left to filter properly. In some people, a small rise in creatinine after starting an ACE inhibitor or ARB is expected and even acceptable under supervision. Medical reviews often note that a rise up to about 30% can be tolerated with monitoring, but that only applies when the patient is otherwise stable and being followed correctly. If the rise is larger, or if it happens during illness, fluid loss, or drug interactions, now you're no longer talking about routine adjustment. You're talking about potential injury, and that distinction matters enormously. Let me tell you the warning signs that I never want you to dismiss. If you're on any of these medications and you notice you're peeing much less than usual, that matters. If your urine becomes dark and strong smelling, that matters. If you feel newly dizzy when you stand up, that matters. If your mouth is dry, your pulse feels faster, your muscles cramp, or your energy suddenly collapses for no clear reason, that matters. If your weight drops rapidly on a diuretic and you weren't trying to lose weight, that matters. If your ankles are suddenly more swollen while your urine is lower, that matters too. And if you develop weakness, palpitations, or a heavy, strange feeling in your chest or limbs while on spironolactone or an ACE inhibitor combination, do not brush that off as stress. Those can be electrolyte warnings, and electrolyte warnings can escalate fast. The next sign is one most seniors misunderstand, and that is, I feel fine. Feeling fine does not mean the kidneys are fine. Early kidney injury can be almost symptomless. That's why blood work matters so much. Creatinine, eGFR, potassium, sodium, sometimes urine testing. These numbers let us see what the body cannot feel yet. I've seen patients walk into clinics smiling. Blood pressure excellent, no pain, no fever, no complaint other than being a little tired, and their lab results looked like a flashing red alarm. That is the silent nature of kidney damage. It hides behind ordinary days and vague symptoms. And if your medication was started or increased recently, or if you've been sick, or if you've added something over the counter, that little tired can become very important. This is why regular follow-up is not bureaucracy. It is kidney protection, plain and simple. So what should you do if you're over 60 and one of these medications is sitting in your daily organizer? First, know the name of every blood pressure medication you take, not just the little white one. Know whether it is lisinopril, losartan, hydrochlorothiazide, chlorthalidone, furosemide, spironolactone, or something else. Second, know why you take it. Is it for blood pressure, swelling, heart failure, kidney protection? Third, know what labs are supposed to be monitored. If nobody has explained that to you, ask. And don't be shy about it. You are not being difficult. You are being medically responsible. Ask, when should my kidney function and potassium be checked after this medicine starts or changes? That one question can save you from months of silent decline. It also tells you whether your care plan is active or just running on autopilot, and autopilot is not good enough after 60. Fourth, get a sick day plan before you need one. This is huge. If you get vomiting, diarrhea, fever, poor intake, or heavy sweating, you need to know in advance whether any of your blood pressure medications should be temporarily held and when to call. Don't make that decision from memory while you're dehydrated and exhausted. Have the plan ahead of time. National Kidney Guidance stresses planning for illness because dehydration changes everything. The same pill that is safe when you're well can become risky when you're volume depleted. And please hear me clearly here. This does not mean stop medications randomly on your own forever. It means ask your own clinician for an explicit sick day rule tailored to your conditions. That distinction matters. The safest patient is not the one who panics and quits every pill. It's the one who knows exactly what to do, when to do it, and who to call if something changes. Fifth, be extremely cautious with over-the-counter pain relievers. This one catches people constantly. Ibuprofen, naproxen, some cold and flu products. These can strain the kidneys on their own, and when paired with ACE inhibitors, ARBs, or diuretics, the danger rises. I cannot tell you how many seniors think the prescription medication is the whole story when the real kidney injury arrives through the combination. One prescription, one over-the-counter pain reliever, one dehydrating illness, and suddenly the lab results are terrible. So if you have kidney disease, diabetes, heart failure, or you take blood pressure medicines that affect the kidneys, ask the pharmacist or your doctor what pain or cold remedies are safest for you. Don't assume the stuff sold without a prescription is automatically harmless. It isn't. Over the counter does not mean over the risk, especially when aging kidneys are involved. Sixth, watch trends, not just snapshots. A single normal blood pressure reading does not mean the medication is perfect for your kidneys. A single day of extra urination does not mean the swelling is cured. A single week of fatigue does not mean you're just tired. Look for patterns. Are you drinking less but still taking the same diuretic dose? Are you losing weight quickly? Are you eating poorly? Has your urination changed? Have you felt weaker since the dose increase? Have your lab checks been delayed? These are the patterns that matter. And if you're a caregiver for a parent or spouse, this applies to you too. Often the senior taking the medication normalizes symptoms that are actually warnings. They don't want to bother anyone, they don't want another appointment, they don't want to seem fragile. But kidneys do not care about pride. only about physiology. Seventh, never confuse a lower blood pressure number with automatic safety. This is one of the biggest misconceptions in senior health. People think my pressure is down, so everything must be working beautifully. Not always. If the medication lowered blood pressure by drying the body out too much or by dropping kidney filtration too far, the number can look good while the body underneath is doing badly. That's why the real goal is not just lower blood pressure. It's lower blood pressure with stable kidney function, stable electrolytes, and a person who still feels like themselves. If you're dizzy, faint, confused, weak, or peeing far less, a pretty reading on the monitor does not cancel that out. And if you've been told your numbers are excellent, but you feel awful, do not ignore your body. Excellent numbers with worsening kidney labs are not victory. They are a clue that the treatment plan may need adjustment.